a grandmother, a confession, and a grandson with hospital access. But here's where this gets forensically vicious. The toxicology didn't just prove he killed her. It proved when, within seconds. And it would have been missed entirely if someone hadn't done the blood work right. Welcome back. I'm the bad chemist. This is the case that changed how we think about mercy-killing evidence. Let's nail down the legal difference because it matters forensically. Active euthanasia? That's legal, in exactly 8 places globally. Doctors, forms, oversight, clean. Mercy killing? That's a family member saying, I'm ending this because I think they're suffering. No physician, no paperwork, illegal everywhere. Here's the forensic nightmare. They can look identical at autopsy. Both can be injections. Both can be clean. That's where chemistry saves us. Our victim, 72 years old, heart failure, COPD, kidney disease, breast cancer, invasive ductal carcinoma. She was done. The grandson, drug abuser, security guard at a hospital, had access to sterile equipment, and he confessed. Said grandma asked for it. Said he did her a favor. That confession doesn't prove anything toxicologically, but it gives us a timeline to attack. She's found supine on her bed, covered with a blanket. But the flat is chaos. Blood everywhere. Passive stains, transfer stains. A razor blade sitting in blood down the hallway. Butterfly needles. A scalpel. Unused. And here's the trap. Without blood work, you look at that razor blade and the superficial cuts and you think self-harm or staged suicide. It looks like she did this to herself. That's exactly why we don't trust our eyes. That's why we do the chemistry. His written confession is specific. He states, alprazolam first, 6 milligrams, a benzodiazepine, calms you down before the needle. Then heroin, 3 grams intravenous. And here's the claim. Breathing stopped 1 minute later. 1 minute. That's a testable hypothesis, and we tested it with blood chemistry. Here's what the pathologist sees. A superficial T-shaped cut. Multiple incisions layered on top of each other. Hemorrhagic infiltration, bleeding into the wound edges. This tells us she was alive when this happened. Blood was still pumping. 1 fresh injection site. Punctate defect. Hematoma around it. But here's the problem. An elderly woman who's had blood work, IV lines, medical procedures, those marks blend in. They disappear into noise. Without a flagged suspicious death, this case goes natural causes and closes. Nobody orders toxicology. Here's the morphine. 1.7 milligrams per liter. That's the active metabolite of heroin. Alprazolam, 0.020 milligrams per liter, the benzodiazepine. Cocaine, 0.021 milligrams per liter, present but low. Her prescribed beta blocker, 0.024 milligrams per liter, therapeutic level. The morphine concentration? That's acute intoxication, respiratory depression, cerebral hypoxemia, death. But the headline number, the one that clinches it, is sitting in the next slide. 6-monoacetylmorphine. This is the direct metabolite of heroin, not a degradation product, not a contaminant, not something that sits around. When you inject heroin, your body immediately starts converting it, and the intermediate product, 6-MAM, is only present for minutes, maybe 10 minutes tops in blood before it's gone. We detected it, 0.028 milligrams per liter. That presence is forensic proof of one thing: recent heroin administration. And the absence of it in older bodies? That tells us she didn't survive long enough for it to be metabolized further. We also detected codeine and noscapine in her blood. These are common contaminants in raw opium. They don't come from pharmaceutical morphine. They come from heroin, street heroin specifically. This isn't pharmaceutical. This isn't accidental. This is intentional administration of illicit heroin. The contaminant profile confirms the administration vector. He used street heroin. That's not a compassionate mistake. That's premeditated. Now watch this. This is the detail that destroys reasonable doubt. Alprazolam, the benzodiazepine, was detected in her blood. 0.020 milligrams per liter. But its metabolite, hydroxyalprazolam, not detected. Here's why this matters. Alprazolam doesn't just sit in your blood. Your liver immediately starts processing it. The metabolite forms quickly. The absence of that metabolite means one thing. She died before her liver had time to process the drug. He said 1 minute. The chemistry says probably less than that. This isn't matching his confession. This is exceeding his confession. He said 1 minute. The evidence says seconds. But here's what we don't see in the hair. Hair captures drug use over months. We tested her hair going back 90 days. Cocaine? High. 41 nanograms per milligram. This grandmother was a user. Chronic cocaine consumption over 3 months. Alprazolam in hair? Nothing. This benzodiazepine wasn't part of her routine. It wasn't her prescription. This was a one-time terminal administration. That distinction matters. She wasn't a regular benzodiazepine user. He brought it specifically for this event. His account. Breathing stopped 1 minute after injection. The evidence. 6 MAM present, indicating injection within minutes. Hydroxyalprazolam absent, indicating death within seconds to maybe a minute. These two independent metabolite findings confirm his timeline. Not approximate it, confirm it. That's not a lucky guess. That's not a coached confession that happens to be right. That's forensic precision. The chemistry proved the timeline. That superficial cut? Without context, it's self-harm. That injection mark? In an elderly woman post-medical procedure, it's noise. The flat's chaos? Consistent with depression, substance use, medical deterioration. A pathologist looking at this without a flagged suspicious death closes it as natural causes. COPD, heart failure, cancer, take your pick. Reasonable causes. Toxicology never runs. Evidence disappears. Case is filed. That's how elder homicide gets missed. This isn't unique. The Australian homicide study from 2001 to 2015 shows the pattern. Victims, typically under 75, multi-morbid, living with family. Perpetrators, history of illicit drug use, mental illness, exposure to violence. Relationship, familial or intimate. Our case? Textbook match. 72-year-old grandmother, drug-addicted grandson. Living situation, access, knowledge. This is a recognized vulnerability profile. Forensic pathologists should be primed for this. 3 takeaways for the field. First, meticulous documentation. Every bruise, every mark, every injection site, no matter how minor, because the mark that looks medical might be homicidal. Second, maintain suspicion. An elderly person with chronic illness found dead? That's not natural until the chemistry proves it. Request full toxicology, always. Third, recognize at-risk scenarios. An elderly person living with a family member who has drug access and addiction? That's a vulnerability flag. Documented. The trial acquitted him. Exceptional mental state. His life circumstances were tragic. So despite the bulletproof toxicology, despite the timeline, despite the chemistry, the law saw mercy in the method. But here's what matters for us. The forensics worked. The chemistry was unassailable. It proved what he did and how fast it worked. Whether that becomes justice, that's not our job. Our job is the truth. And the chemistry told it. This case is from 2024, Zwerner et al. In the Journal of Forensic Sciences. It's a masterclass in why toxicology matters, why attention to detail saves investigations, and why elder vulnerability is a forensic priority. If you work in forensic pathology, read it. If you're in grad school, study it. If you care about why the chemistry is the evidence that actually speaks truth, subscribe. Stay sharp.